okay, with a history of feeling palpitation on and off. Okay, you ask about the red flag. You didn't find any red flag, but the issue is, so what the red flag that you will? Let me first open it. I'm not sure where it gone. Yeah, it's there. So so he's coming with palpitation. Okay, feeling heart racing on and off.
I'm
Okay,
sorry, it's a young patient. How young?
young is in 20s. Okay, 24, 25. Yeah,
Because young
and
here is different, quite different.
huh?
Young here, I mean, until 60 is still young.
Okay, that's okay. We'll say youth, not young. Okay,
Right.
so
You ask,
and
you know, palpitation, of course, the red flag will be what this is with exercise, exertional palpitation or
okay,
no. This is the
okay,
more important. And is it accompanied with the syncope, pre-syncope, um, yeah, chest pain and all those kind of things.
yeah.
Um, yeah. Uh,
No, and what
so,
else? There's a couple of things important also. Family history of early
oh yeah,
disease,
yeah,
early death. Yeah,
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 of course, the family history of
yeah,
cardiac death and
yeah.
yeah, and what else? I'm not sure because if he's young,
And
we
and
we
and if he's athletic, because this is crucial. Okay, how many foot players died on fields. Okay, these people, yeah, this the athletic heart, especially. That we have category in the cardiology called the athletic heart. It's very difficult category. They are very prone to VTAC and VF because of the bulk muscles of the heart and then accessory pathways. They can easily enter to VTAC.
this
Okay,
is
and the
right.
Brugada syndrome and which we will take all of these detailed in the future, inshallah, as I'm planning. Uh, yeah, so yes, yes. Well, so say you didn't find any red flags. Okay, would you ask anything else related to palpitation?
Well, onset, offset,
Yeah.
is it sudden onset or sudden offset?
Mhm.
Uh, yeah, I would probably ask the patient how to, demonstrate it, like, tapping it or something. That's kind
Yeah.
of, yeah.
Yeah, regular, regular. But there
And
is
how
one
to follow.
important thing. I think we are not aware about it, fully. Uh, it's very important to ask the patient about their body position while they having the palpitation. Okay, because positional palpitation is something serious, is not something you need to take it lightly. Okay, if patient having atrial myxoma or cardiac cancer. Okay, the position of the tumor can precipitate the palpitation. So if the patient is telling you, I'm always having the palpitation and I'm lying down, this should trigger for you something there. Okay. And the opposite, that which is not completely innocent but lesser dangerous, if the patient is saying, oh, I'm getting palpitation when I'm standing up, that should trigger something for you, because these are completely different, different diagnoses. Okay, so with the lying down, always think about possibility of atrial myxoma. Okay, or any compressing tumor around the heart. Okay, when standing up, always think about what is called POTS. Okay, and we will discuss what is POTS is. Okay, yeah, that's also, please put it in your differential plus for sure if he's taking drugs and this. So this patient, if he's taking, for example, steroid, okay, so he might present with the tachyarrhythmias. Okay, so that's also important. Or if he's taking thyroxine, he'll present with tachyarrhythmias. Yeah, and chest pain for sure, as you said. Anything else you would like to ask before doing the ACG?
In
Hello?
terms of you mentioned like diaphoresis, or the patient is having lightheadedness, or
Yeah.
it, yeah.
So these are the red flags regarding the arrhythmia, but then the red flag regarding the cause of the arrhythmias. Yeah, and perhaps you might consider asking that maybe after knowing what is the type of the arrhythmia is. So if the nurse went and did the ECG for you and then it bring for you the ECG, can you tell me how you will proceed for it? Because I want today to give you, to give you all an approach, okay, how to proceed for any, tachyarrhythmias. And then in each week, coming week, we will do some modification in this approach, okay? But it's only simple three steps, okay? And the modification will depends about the finding. So if you see that ECG, what you how you will approach to it? We will. It's something related to the rhythm, okay? And, it's not something related to, because according to the poll on the WhatsApp, most of the people said that they would like to hear more about arrhythmias rather than about myocardial infarction. So that's why I put arrhythmia. Today the problem is in the arrhythmia, okay,
Yeah.
and the heart rhythm. Yeah.
Well, I'm not going to. The usual thing what you do is just you go from the basics, like you check
Mhm.
the weight. Actually, you
Okay.
check if it is the right calibration. Of course, you check those. This is the right calibration of the ECG, but you're going for the rate, rhythm, and axis, and then you go
Okay.
P wave QRS complex, and you take it from there. And so you see like the QRS complex. If the QRS complex is narrow, then
Yeah.
you
Excellent.
check if this is or wide. So you check if this is what a regular or irregular rhythm,
Yeah.
and if it's a irregular rhythm, then you go if this is tachy or brady, and then you decide upon if this is tachy and irregular. So you're just thinking about two things: sinus tachy or atria flatta. Um, so if this is irregular, you're thinking about AF, atrial fibrillation. And then if you take the other hand, which is the what we call it, the white QRS complex.
Yeah.
I mean, if we're saying that the other one is regular, I mean narrow, regular, and brady arrhythmias, and you're thinking about, or the only thing you're thinking about here is the heart blocks, all types of heart blocks here. It depends on
Yeah. Yeah. Completely. Yeah. You said you said most of the algorithm. Yeah, completely with you. That's perfect. So
yeah.
what do you think about the rhythm here?
All right, so uh, well, I think hold on, is this to no, I think it's regular rhythm for me.
Hmm.
It does look like a regular rhythm, not a complex,
Hmm.
and QRS, narrow complex QRS, regular rhythm, and the P wave. This is a P waves there, and every P wave is followed by QRS complex. So this seems to be like so if we counting the rate, so this is 100. This is 300, 150. So we're talking about 120 or so.
Yeah, exactly.
Uh,
Around 120.
yeah. So I think this is my sinus tachycardia, but there's quite changes in the other leads, which is we have in some sort of ST depression.
Yeah, which usually rate related. So it's not unusual if you have sinus tachycardia, you will find some ST segment depression, especially if the patient is asymptomatic.
Yeah.
It's rate related. Mean the heart will be in strain, and will
Mm,
be some ischemia there
yeah.
because of the rapid heart rate.
Well,
That's completely right. That's completely right.
uh,
I'm
I,
happy.
I, well, because there is tall, tall. T wave here as well.
Yeah,
Uh,
but that no, I will be against that. It's not tall. I will tell you why. So so if you can see that any T waves before it's having a deep RS, so you can see the S wave. This wave is very tall, isn't it? This one,
mm,
two, three, four, around maybe five. Okay.
uh,
So proportionally, the T wave here is large because of the S wave. So this called proportionate T wave. If it's proportionate T wave, don't worry about it. Okay. So, which usually every large square here will be around one small square here additional. Okay. So more or less, it will not be something you need to worry about, okay? Because it's
mm,
proportionate T wave and even proportionate to ST segment elevation. So I won't bother by it, to be honest. I won't be worried. If it's disproportionate, mean you have R wave and and the S wave here is not that deep, say for here,
okay.
and this
Yeah.
is a T wave. Oh yeah, I will, this acute T wave, which mean that might be early MI. So,
Mm.
but in this ECG, I won't bother. I won't bother, to be honest.
Yeah, yeah, yeah. Yeah, of course. Yeah.
So yes, exactly, Dr. Ahmed. As you say, this is sinus tachycardia. But then the question is to treat or not to treat, or how to proceed.
Well, just this is some sort of a palpitation that is. I'm assuming that is having palpitation. Is again. So this is a This is symptomatic patient. Then yeah, but again, it depends on other symptoms that he's getting with as well. And also how much this is interfering in his life. So I would probably treat it if there is any other um, red flag, or or this is interfering with his daily activities actually.
Yeah.
Um, yeah, I think otherwise, if this patient is fit and well, have no history, family history of any cardiac disease, I wouldn't actually treat it or investigate it further.
Okay. Yeah. Well, this was my concept, until 2 months ago. So yeah, I thought, okay, treatment of sinus tachycardia. Well, sinus tachycardia is an innocent, but and innocent rhythm if there is no secondary cause for it. Okay, so with the patient that present with sinus tachycardia, you need to search for the secondary causes. Okay, because sometimes sinus tachycardia can presentation of PE. Okay, so if there is no secondary causes, like the patient doesn't have fever, dehydration, PE, or any stresses related sinus tachycardia, so usually we will say, okay, this innocent tachycardia, no need to treat. But then there is the other two syndromes. So they now differentiating the sinus tachycardia in three categories. Is it appropriate sinus tachycardia? Is it inappropriate sinus tachycardia, or it's a POTS syndrome? Okay, which was something also new information for me, to be honest. So treatment of appropriate sinus tachycardia mean that patient have sinus tachycardia due to a cause, is treatment of the cause. But then inappropriate sinus tachycardia mean the patient is having always sinus tachycardia all over the day without any specific cause. And that's very annoying, okay, because that is putting his heart in a strain. And the only way to diagnose this patient is doing a Holter ECG. So they will find his resting heart rate 100 plus and his even exertional heart rate 100 or 150 plus. So, and that how they are diagnosing it. And then such patient, on the long run, their heart will be in strain and myocardial ischemia can develop. So they intend to treat it. Okay, and the problem that most of these cases, unfortunately, we are not aware about it because we are accusing them that they having an anxiety disorder. And it's always, and not uncommon that these cases will be treated as an anxiety, and actually they don't have an anxiety. They have what is called inappropriate sinus tachycardia, and there's just something dysregulation of their sympathetic nervous system. This is one category of him, and then what is Potts syndrome, which we'll talk in detail about it. The Potts syndrome. So the Potts syndrome is postural sinus tachycardia. So when the patient had change his position, he will start to have sinus tachycardia, especially if it's from from sitting to standing, like orthostatic hypotension. So they find that also there is something called posture sinus tachycardia, which once the patient is changing his position from lying to standing or from standing sitting to standing, he will start to have tachycardia, and it usually will be symptomatic. Also, that's need treatment, and the only way of diagnosing that is doing heart rate sitting and standing, like you are doing heart rate and like you are doing postural hypotension or static hypotension, sitting and standing. Um, and the difference between the sitting and the standing heart rate should be around 40 or 30 beat per minute, with more or less stationary or stable blood pressure. So this was new information for me, and again, also the all the the papers regarding inappropriate Potts syndrome was saying that this patient, unfortunately, in the primary care was misdiagnosed as an anxiety and treated as an anxiety, and actually this is not the proper treatment. The proper treatment is as orthostatic hypotension. Okay, you will give fluid expander, increase fluid intake. You can give them, elastic stocking, calf muscle exercises, and then you might consider using beta blockers, okay, like propranolol or ivabramine, or even fludrocortisone. Okay, so this was the new information for me. That's why I wanted to share it with you, doctors. So and I will show you the PowerPoint, and the science behind it. Um, is the PowerPoint seen? You can see. Is it shown? The PowerPoint. Can see, Dr. Ahmed, the PowerPoint.
Yeah, yeah, yeah.
Yeah. So as you said, Dr. Ahmad, so when you are approaching any tachycardias, okay, is the first question is it tachycardia or not? So if the heart rate more than 100 is it tachycardia. And then the second step is to, to categorize it. Is it white complex tachycardia or neurocomplex tachycardia? And the cut limit of if it's three small square or the QRS complex is three small square or more than three small square. Okay, if it's less than three small squares, shows a narrow complex, and then you will see, okay, is it regular or irregular? Today we will take the regular one, okay, and we'll take the first one, which is the sinus tachycardia, and then next week and the week after we'll take the flutter and BVCs, the supraventricular tachycardia. So it's very simple. If it's not a complex regular tachycardia, it's one of three things: either sinus tachycardia, either supraventricular tachycardia, either flutter. Okay, flutter. If you find the heart rate 150, consider the ECG is flutter to prove otherwise. Okay, because 150 usually the sinus tachycardia will not reach that. Okay, usually what sinus tachycardia will reach 130, 140, but 150 usually the flutter wave will be hidden somewhere in the ECG. SVT can reach to 200, to be honest. So SVT will be more than 150, and then or less. So if it's more than 150, approaching the 200 or 200 plus, this is mostly SVT. Okay. So these are the three steps, okay, of diagnosing tachycardias. Okay, if it's more heart rate more than 100, narrow or broad complex, and then if it's narrow, regular or not, and then if it's regular, then is every P wave followed by QRS complex or not? Yes, then that's most probably sinus tachycardia or low atrial beats. But how you will differentiate, you need to look at lead 2, 3, and AVF, which are the inferior leads. Why? Because the inferior leads are directly looking at the right atrium. If the B wave in 2, 3, and AVF is positive B wave, then this is absolutely sinus tachycardia. If it's negative T waves, that means low atrial tachycardia, and this will take it next time. Okay, so please, please, please look at the P waves direction in the inferior lead. If it's positive and each P wave followed by QRS complex, and the QRS complex is narrow. So this is sinus tachycardia. And then the next step for that you will need to see if it's, appropriate, inappropriate, or postural. Okay. And we already explained what is appropriate and inappropriate and postural. An additional step with every tachycardia, usually I'm doing in the practice, is trying to calculate what is called the maximum heart rate. Okay, so the maximum heart rate means that the maximum physiological heart rate that this patient may, be able to stand it without having symptoms of ischemia. Okay, and usually I'm calculating that with the patient or with atrial flutter, so I would be able to predict, is it safe for me to try to control the heart rate in the community or not. We know that, according to the guidance, if the heart rate more than 130 in the atrial flutter or atrial or AF atrial fibrillation, usually it's indicated to refer him to the secondary care to do heart, to control the rate. But sometimes if I feel that the patient is hemodynamically stable, I would, I would consider, keeping him at least during my clinic, um, to control his heart rate. Okay, and the one thing that would help me or put me, my brain in a safe mode, that is he reaching his maximum tolerable heart rate or not. And usually the calculation of it by simple calculation. So you're multiplying his age in year by zero point 0.7, and the number that will come, you need to subtract it from 207. And then that will give you a number. If the heart rate, calculated heart rate of the AF, approaching that number, either exactly or more, then you need to refer. Okay, if it's less than that, I would try to give him some bisoprolol or calcium channel blocker to control his heart rate in the community. The other terminology that I would like, perhaps you to know, is what is called the heart reserve. You will find that in the report of the people who's coming from pulmonary rehab or cardiac rehab, because the heart reserve is a calculation in how much his heart is fit, and it's depending on the maximum heart rate and the resting heart rate and the difference between them. And the more the heart reserve is low, or high, sorry, high, the more that the patient is, his heart having capacity to perform better. And usually we decalculate that in the cardiac rehab programs. And the importance of knowing that is just, guidance for you, how bad or how good the patient heart is. Okay, and explaining to him what is the importance of doing exercises and the importance of having resting heart rate, in the lower side. And that will not happen except with good physical condition and reconditioning. So this is all. Then the indication of the Holter, okay, because not every patient with arrhythmia will need the Holter. So if you did it in ECG and you already discovered the arrhythmias, so you don't need to send the patient to do Holter ECG, except if his symptoms is not explained by the ECG findings, then you might consider Holter, okay? This was also a point that I needed to emphasize, because a lot of doctors, when I was talking with them, they think that even if the ECG is showing some, picking up some, arrhythmias, that you need to send them for Holter. No, if the 12 lead ECG pick up an arrhythmia, and the arrhythmia explaining the patient's symptoms, so you don't need to do for further Holter ECG. And that's what we call what is appropriate and inappropriate and POTS. I hope it's clear, but I need to do, some further, elaboration of POTS syndrome, which is postural tachycardia syndrome, and the treatment. Okay, and as I said, the difference between the sitting and the standing heart rate is 40 or 30 according to the age. So 40 will be in the teenager, 30s is about above the teenager age. Um, the important also of POTS, that you will find it more prominent in the patient that having post-COVID syndrome. Okay, and as I said, also they are usually misdiagnosed of having an anxiety. The theory behind it that there is, several subgroup of it. So sometimes will be hypovolemia or autonomic dysfunction or hyperadrenergic even state. So the patient having, a lot of energy drink, and having a lot of adrenergic surge that can present with such symptoms. Okay, and the other thing is the deconditioning. Clinical assessment is, it's diagnosis of exclusion. So you need to do exclude all the other possible causes of sinus tachycardia, and then after that you need also to do the sitting and standing heart, measurement. Okay, the difference between it and between the postural hypotension that usually we are doing the heart, the blood pressure at 1 minute and 3 minutes to diagnose the postural hypotension. But in Potts syndrome, you are doing it after 10 minutes. Okay, 1 minute and 10 minutes, not 3 minutes. Okay. Further investigation could be, at the hospital. So the NASA test and the head tilt test or tilt table test is in the secondary care, not in the primary care. Uh, Treatment wise, as I said, which is the same treatment of the postural hypertension, more or less. Okay, fluid intake, increasing the salt intake, doing more physical exercises, avoiding alcohol or heavy meal, and also elastic stocking. Medication wise, you can use beta blocker like propranolol. You can use evadrapine, okay, which is potassium channel blocker. Uh, Pyridostigmine, to be honest, I didn't use it in such indication, but it's written in some papers. Midodrine, yeah, people who's, who used to practice in Egypt, well, it's a common practice in the Middle East to use midodrine, and it's written here in the in some of the papers in the UK. Alpha blocker like methyl dopa or clonidine also can be used, and volume expander like fludrocortisone. So please don't consider sinus tachycardia or as a simple things, and that you just reassuring the patient you don't need a treatment. No, sometimes these patients need a treatment, and that will make a big difference in their quality of life. And I think this is our main goal as a physician is to have, is to try to let the patient reach a better quality of life. Yeah, I think the end of the ECG. I hope the things are clear, and I'm happy for any